Hello everyone, I'm Susan Deuchars and I'm the chair of the Conferences Committee at the Physiological Society.
Hi everyone, I'm Steve Mathieu. I'm a critical care consultant in Portsmouth and the treasurer for the Intensive Care Society.
Hi, and I'll just say hello, I'm Mike Tipton and I'm the editor-in-chief of Experimental Physiology.
So on behalf of us all, the career organisers Mike and Hugh Montgomery, who's not here at the moment, we really extend a warm welcome to you all, whether you're a student, a researcher, an academic, a critical care clinician or a healthcare practitioner. You're joining us from all corners of the world as we start this rather unique conference focusing on COVID-19. And as we cope with the storm of the second wave of infections and start to roll out the first of the vaccines, it seems really timely to stop and consider what we've learned from this year of treating patients who've presented with pathophysiology in many organ systems, and also to understand what researchers have gleaned in determining the mechanisms underlying the damage observed. So conferences such as these, we believe, are critical to enable information to be exchanged from the different viewpoints and experiences of researchers and clinicians. Now, before we start, I'd just like to say a few thank yous. So hopefully you can see this. To say a few thank yous to the members of staff at the two societies who've worked tirelessly to support both this meeting, but also to pivot all of our meetings to online platforms. And they've also enabled us to put on a full programme of webinars covering many different research areas, tips for online teaching and getting back into the labs, but also providing support for those whose mental health has been affected. And I'd just like to remind you that we've got a satellite symposium at the end of day 2 on this. So to thank the people from the Intensive Care Society, we've got Sandy Mather, who's our Chief Executive, and Alex Day, who's the Head of Communications and Engagement. And from the Physiological Society, we've got Sarah Bundock, who's our Events and Marketing Manager, and Caitlin Oates and Rosie Heinard, who've worked tirelessly to put the conference on. They're our Events and Marketing Officers. And of course, Simon Rallison, who's Director of Scientific Programmes. We are so lucky to have such professional, positive and hardworking staff working with us. Okay, over to you, Steve.
Thanks very much, Sue. I'm really excited about the collaboration between the Intensive Care Society and the Physiological Society. It's been a real sort of welcome distraction in some ways, organising this conference, and I think it's been done extremely well and to very high standard, and I'm very grateful for that collaboration, and echo exactly what Sue said. There's a lot of people behind the scenes that have done an awful lot to get us to where we are, so thank you to all of them. We're bringing experts in physiology together with healthcare professionals, scientists and researchers to help share knowledge and lessons learned about COVID. And I'm very much looking forward, as I say, to more of this in the future, because I think between us and the Physiological Society, we can improve our understanding of pathophysiology and how this can directly benefit our critically ill patients at the bedside. So on behalf of all of us, thank you. Thank you to our speakers for giving up their time, and thank you to all the delegates for joining us. We appreciate many are working at the front line and would like to thank each and every one of you for helping us advance patient care and to improve outcomes. Do enjoy the conference, submit questions to the chairs, interact as much as you can with our speakers during the Q&A and the panel discussions, and we wish you well. Thank you. Back to Sue.
Okay, thanks very much, Steve. And I'd like to now introduce our two first speakers. I think we've got two, or it may just be Andre. So they're going to be looking at the challenges faced with COVID-19. And I'd like to introduce Dr. Andre Vercueil, who's a consultant in intensive care medicine at King's College London. So Andre, over to you. Thank you very much for joining us.
Thank you very much, Sue, and thank you for having me to this unique collaboration. I'm sure we're all going to enjoy it. So it seems like not very long ago now, or a lifetime ago, should I say rather, that we first heard that there was this virus in Wuhan that was making its way towards us. And I don't think we quite knew what was going to happen to us. But I think we now know it as really truly the COVID curveball, because what happened was really quite something. So we knew about coronaviruses. They're envelope viruses, of course. They've got single-strand RNA, and their peplomers, those little red things, the spike proteins, are glycoprotein spikes which bind to receptors. They're a big family of viruses. They cause, a majority of them cause mild to moderate upper respiratory tract illnesses, the 4 of them that we know, including the common cold, by the way. But there are a very large number of them in animals, more than 5,200. Things like pigs, camels, bats, cats, civets, etc. And we know that at least 3 have jumped to humans, so-called spillover events. Oh, it's next slide. There's something really important about these viruses, and pretty much everyone will have some familiarity with it now, the so-called R number and the K number. So the R number, or RT to give it the proper name, is the average number of people an infected person goes on to infect. But this number doesn't tell you everything that you need to know about this virus, because what's also extremely important is the K number, the dispersion parameter. And that tells you how variable the infection can be. And it may be the truth that a small number of people, at least a moderate number of people, infect nobody, but that small numbers of people go on to infect many others, and thus causing these so-called super spreader events. What has this crossover? We talked about crossover. What's it been driven by? Well, largely by habitat destruction. So humans are encroaching on animals' habitats, and we forced into proximity with these wild animals, which carry these other 5,200 coronaviruses. And this has altered their predation and the way that they have to obtain food. And they find it close to us because it's easier. It also has changed with our farming patterns. And here you can see the battery farming of chickens, the practice in China of having chickens underneath pigs, or pigs underneath chickens, should I say. What else? Well, bats seem to be incredibly important when it comes to this particular new virus. And bats may have spread the virus directly to man in the spillover event, or there may have been an intermediary with pangolins. Is it really one virus? Well, that's not abundantly clear. There may be different types of viruses that are ever so slightly different. And the G164 may be dominant over the D conformation of the virus, favoring the so-called open spike conformation, which may increase infectivity. Another source in Europe in particular is, and in Asia, is mink. And you can think of that as mink madness, because who honestly wants to wear mink nowadays? But it's common, and I'm sorry if you find these scenes distressing, but that is what it takes to make a mink coat, which of course is very popular amongst segments of the population. And I think it's worth remembering that if anyone has anything like that. Denmark certainly continues to have 40 mink farms with 170 new variants of virus. And there seem to have been 5 clusters of viruses. And it seems that half of all the Danish COVID is probably mink related. In particular, cluster 5, there were 12 cases with a so-called Y453F mutation that may have had a limited impact on convalescence. Was this really vaccine escape? It's uncertain. There are also mink cases in another 5 countries as well, including France, as we can see here. And as I said, there seems to be a mutated virus here that we don't really know whether it's different to the one we saw in China or not. How's the virus spread? Well, I think most of us are becoming familiar with this. It's either spread by droplets, so-called ballistic spread, but more of it is now in the form of aerosols. And it seems to be the major source of contagion in humans. However, it is also possible for it to be spread by fomites, which last for 2 to 3 days on hard surfaces, and for up to 28 days at 4 degrees Celsius, which may be why there have been lots of outbreaks in meat workers. What's happened in the UK? Well, this was the UK at the beginning of March. And what we saw, the R number was really rather high then. And we knew then that we were in real trouble. And so we did something about it, which was lockdown, and that was trying to shift the R number to the left, trying to get it below 1, because once it's below 1, the virus is no longer spreading as effectively in the human communities. Because we talked earlier about super spreader events, well, the Skagit Country Choir practice, there was one symptomatic person in that choir and it resulted in 53 cases. So that's an example of how a dispersion event, the K number, can dramatically infect how the virus spreads. How does the virus gain entrance into our cells? Well, it's of course via the ACE2 receptor, and it's a sodium-dependent neutral amino acid transporter. The spike protein that we talked about before is a protein trimer. It's a 1 up, 2 down conformation, as you can see at the top left of the screen. And that causes the ACE receptor to bind with the angiotensin 1 receptor, and that causes stabilization on the membranes and allows fusion of the viral and cell membranes. The virus really enters and lysosomal proteases release the RNA. And it takes about 96 hours to gain respiratory epithelial cell entrance. And what we now know is that the virus spreads asymptomatically, and that's really, really, really important because we can see that a majority of viral spread is when people are asymptomatic, and that was not known until relatively recently. And a majority of people are not infectious by day 8 to 10 of having the virus, but it's but the problem is that early period when people are highly infectious but don't know about it. And we know that with an R0 of less than approximately 3.6 worldwide, 52.7 million people around the world were infected by November the 13th. That's truly dramatic. It was 68.5 million by December the 8th. And it's about 74 million people today are infected worldwide. And if we just think of a small number of those converting to becoming intensive care patients or needing hospitalization, it tells you something about the huge impact that this disease is having. The total number of cases, confirmed deaths and cases is probably, as we said, around the 74 million cases. And it's probably a lot higher than that because there's limited testing and various countries challenge the attribution of COVID in the causes of death, including the UK, by the way. And why is this? Why does it spread so effectively? Well, if we look at an R number of 3 there, with each person, on average, infecting 3 other people, we can see that exponential rise. But it's 3.6 now. So if we round it up to 4 for the sake of simplicity of maths and do that, you can see how dramatically it increases the spread. It's a truly, truly infectious virus. And that is something that I think none of us were anticipating. You can look at it pictorially as well. If that's your signature person who's carrying the asymptomatic disease, it looks like this. Inexorable spread. And without either changes of our behavior or a vaccine, that is what it will do worldwide. Truly a tsunami coming down upon us. And I think worldwide, it's been seen as that and looked at as that. So what did it look like in England? Well, I'll just talk about the early period as opposed to the second wave. Well, hospital admissions were above 3,000 a day at one point in England. That was in early March. And then by April, it was falling, as you can see there. But a larger number staying in hospital because these people don't leave hospital in a hurry once they're in. I'll share some data on that later. And those hospital patients translate into ICU admissions. And it was about 10%, as you can see, of hospital admissions needed intensive care in March. And that is what felt like the end of the world, certainly in South London when it happened to us. We were caught completely wrong-footed because the government's pandemic preparations, as they were in the various hospitals, was for a bad flu, and we knew what to do with that. But I think it's fair to say we didn't know what to do with this virus at all. It was not just a viral pneumonia, which is what we were expecting. It affected the lungs, the blood, the gut, the kidneys, the liver, muscles, heart, brain, nerves, spinal cord, and skin. And you're going to hear more about some of these as the conference progresses by people that know a lot more about it than I do. And everyone on intensive care needed support of their clotting. About 72% required advanced respiratory support, 30% advanced cardiovascular support, a very high proportion, 26.7, renal support. That was completely not in keeping with the, other pneumonias. And Claire Sharp will be talking more about that this afternoon. And also, interestingly, nearly 10% developed neurological problems. So truly a multi-system disease, a true intensive care disease. This was not just a viral pneumonitis. And we really need to prepare, because this won't be the last big shock that we face from coronaviruses or other viruses that make the transition to humans. So that was me being Hugh. I'll be me now. I'll just find the next talk. So this is the second part of the talk, and some of the challenges faced. And I'm now going to talk as a sort of a jobbing intensive care clinician that didn't know what the hell was going on. The reason I put the Zoom there is just like we sharing knowledge now, it would have been impossible without it. And the challenges faced that were made much easier by technology. And it was truly something to see. I'm going to give you a bit of context about where I work. So King's College Hospital is quite a big hospital in a deprived part of South London. It's got 1,300 odd beds as of December, and it sees nearly 90,000 non-elective admissions a year. So it's an acute, really busy hospital that is quite different to lots of others. We have about 6 admissions to intensive care a day. And we've got a longer length of stay for our patients, as you can see there. And there are lots of reasons for that. We think it might be due to case mix, but it was very important in the context of this disease. We've got a median length of stay of 4 days for survivors and 3 days for non-survivors. As I said, 69 intensive care beds at the start of this with a high proportion of emergency work. We knew something bad was happening, and we knew it because we'd seen it all in Wuhan, we'd seen it in Italy, and very much Maurizio Saccone, who many of us know well, sent us a message saying, get ready. And he sent it on WhatsApp. And that's quite interesting because that's going to be a theme of this talk as well. We couldn't have got where we got without WhatsApp. So we knew that Italy was having difficulties. We knew that many of them were logistical, the supply of CPAP, the supply of oxygen. And I think that that's what we were anticipating. So we took we listened to him. He said, get ready now with your ITU networks. Don't work in silos. Make sure you've got PPE. Make sure you're trained. Increase your ICU capacity. So we set about doing that. We quickly set up a virology testing at Denmark Hill site. And we started looking around for information. So we had recommendations from China, which we looked at on the internet. And it seemed pretty clear to us that lots of unproven therapies that were not approved for use. And so we entered into trials as a way of looking at things largely. We also knew that we had information from Italy. So we got this, and we had discussions about chloroquine. It was much in the news with Donald J. Trump at the time. And we thought, we started looking at what best practice might look at. So they said, maybe you shouldn't be doing renal replacement because it complicates proning. And we thought, oof, we're going to be proning a lot and doing a lot of trachees. We also knew that, I think very early on, we had information that there may be asymptomatic spread that I told you about. But all of our policies said that there couldn't be asymptomatic spread, and you would only be tested if you were symptomatic. And sure enough, our patients, we started seeing patients. We saw our first COVID patient on the 7th of March, and there was a steady trickle in, and our trust took the decision to lock down completely and stop all elective operating and really start building up lab capacity. So we sort of thought we had a bit of information out there, but as you can see, not everyone in the NHS thought that they had the information. And certainly in Canada, many others felt unprepared and were really worried, rightly, about this financial markets as well. Again, you can see people talking on Maurizio Ciccone again, talking on, from Italy on the JAMA networks, and that allowed us to build a rapid response. So these are some of the things that we were facing, and generate some evidence summaries, and then really wait. And we looked at Europe and we thought, well, we're not doing too badly, are we? You can see the comment there, we're doing something right then. Well, that may have been the myth of British exceptionalism once again here, because pretty soon afterwards, we saw that we were on exactly the same trajectory as what had happened in Italy. So we could anticipate that the same thing was going to happen to us. And sure enough, it did. There were lots of documents coming out. We had the draft NICE documents were leaked pretty early on. This is very early March. And there was a lot of chat about that and about how it was, we were going to be triaging effectively. And we saw actually that most of our patients coming in were young, but they were in their mid-50s, median age of 56 years old. We also knew something else moderately early on, which is that if you lost your sense of smell, that was probably a bad thing. And sure enough, one of the challenges we faced was oxygen, and the fact that by the middle of March, or late March rather, half of our staff were sick with COVID. Because during our planning phase, we hadn't known about the asymptomatic spread and the loss of sense of smell as part of it. So by the 23rd of March, we were using various respiratory care algorithms that we shared on meetings such as this. And we had this incredible surge that led from us going from no patients with COVID in our institution to suddenly 30, and then we were spreading into different clinical areas. And we knew that the logistical challenges were going to be there, but I think we'd completely underestimated the intellectual challenges. And as Hugh said on various calls, we prepared for the flu and for ARDS, but not for this. This was completely different. And after this first weekend on call, Hugh phoned me and said, "What did you think? Because it doesn't look like what we were expecting." So to give you just an overview of the logistical challenges, this was our starting point, as I said, 69 beds. By the time of the peak of COVID at the end, mid-April, we had 145 critical care beds, including 141 level 3 beds. And you can see that was the surge with us. We peaked at about 85 patients, but with a long length of stay. As you can see there, our median length of stay for survivors, 24 days, and a median length of stay for non-survivors, 13 days. So really, it was a truly challenging thing. And we started to talk about, as you can see here, I attempted awake proning. It was really well tolerated. But that increase in oxygenation only lasts while they're proned. And we had a lot of discussions about who we should do it. As you can see, there are names being written because difficulties in communication, difficulties with planning for the Excel and being asked to send staff there. More algorithms, and other people are going to be talking more about this, so I won't really, but we were looking at different modes of ventilation, maybe APRV initially, more generous tidal volumes, less PEEP, and maybe more CPAP. So this constant knowledge exchange on WhatsApp. A friend of mine in the Netherlands sent me this picture to show just what a difficult and creaking system looks like. We were in exactly the same position, only we didn't have a bus like that. This is a little exchange with Hugh after a bronchoscopy of a patient. We started understanding that it wasn't just a pneumonia, it wasn't just a viral pneumonitis. These people had really destroyed airways almost. You can see all the blood in that airway, and effectively the difficulties that you had with ventilating these people, partly on account of that. And you can see that lots of acute kidney injuries. And that was a really big message to us, because that we were not expecting. People very free water depleted with sodiums in the high 150s and 160s. So due to hyperpyrexia probably, and not drinking. This is before they came in. And I'm pretty confident we caused some of the acute kidney injuries by being restrictive in our fluid strategies because they were so hypoxemic. And renal replacement really emerged as a major challenge to us. We had to design new protocols because our filters kept clotting up, and Claire Sharp will talk to you more about that afterwards. And we started talking about this very inflammatory hit, or what looked like an inflammatory hit. Some people being very vasoplegic. So very different, and truly different to what had come out of Wuhan. So we were not expecting this. Was it the same virus? Well, only time will tell whether that was the case. What about steroids? Suddenly we were all talking about steroids again, having the steroid arguments having been put to bed years ago, we thought. But we didn't know. So we entered most of our patients into trials. But we did say, if people are dying and you don't know what to do, perhaps we should try sort of a modified Maduri protocol. We really had seen this group with very high CRPs. We didn't know what the interleukins were at the time. We didn't know what the interferon levels were, but that's a discussion for later. What about enhanced thromboprophylaxis? That was something that came out very early. The filters kept clotting. And when we took people to the scanners, we noticed that a majority of them had pulmonary emboli. Utterly unexpected. And I'm pretty sure that some of the early sudden deaths from our COVID patients, particularly on the wards, were from pulmonary emboli. But we didn't know at the time. And so we started therapeutically anticoagulating some people, particularly if they were having renal replacement. We speculated that it might be causing the AST rises and the renal issues that we saw. And we wondered, should we anticoagulate everybody? This is very early April, as you can see. And this is just emerging information, sharing it with friends, sharing it with the network via this incredible tool that we now have. And the other thing is, the Intensive Care Society was key in launching the National Emergency Critical Care conferences that were really a huge driver for knowledge sharing. And you can see there a synthesis of clinical experience from very early that was shared widely and helped people that were further down the line with the epidemic, because we got hit very, very early and very hard in London. We started noticing, well, we were aware from the Chinese data that there may have been an association with cardiac injury. And we started seeing it in our own patients, by no means all, but certainly evidence of microthrombosis. And we saw quite a number of our patients actually having myocardial infarctions and other vascular events, including strokes, likely due to both large and small vessel thrombosis. I'm running out of time, so I won't even touch on delirium and the other neurological consequences. That's for David Menon's group later in the week. But that also was a major feature of it, prolonged delirium and prolonged unconsciousness after coming off sedation. And really, I wish we had known more at the start. I wish we could have been more onto this incredible disease. I really felt like a witch doctor a lot of the time. But fortunately, we now know a lot more, and I hope we're able to use some of that knowledge to further help our patients and to help others in the world. And particularly you from the Physiological Society, your insights will be crucial to that. So thank you very much. And I think there might be time for some questions.
I'm going to jump in very quickly there. Can you hear me all right, Andre? Fantastic. Thank you very much for picking up. I managed to scoot in briefly from the unit. And as Andre has pointed out, this was an absolute hammering from a disease we really didn't understand at all. And I can't emphasize enough the knowledge sharing elements of this that Andre initiated actually with that call we made on that Saturday going, are you seeing this? We're seeing this. And we, between us, set up a national forum that met once a week knowledge share, just to spread what we were finding. I think that made a massive difference to us all, along with our trial structure. No one got drugs that shouldn't have been, that weren't in a trial. But the purpose of this conference is because we still don't understand the disease. We don't really understand quite how the patients are so hypoxic. Luciano Gattinoni would explain to you the reasons we understand, but there's an understanding behind the understanding we don't get yet. And we're still seeing very strange elements of this disease. I saw someone only last week with peculiar bony involvement of the disease, which was the first one I'd seen. It's still surprising us. We think that doctors working in critical care should work with physiologists. You have the understanding of the diseases, you have the equipment, and we would love to work with you on this sort of problem and others going forward. But I'm looking back at questions to see if anyone's got anything to flag. I'm not quite sure how that works. Do they go into the chat function, Sarah? Is that the way this works? Yes, is the answer. Right, so if there are any questions, we are sticking to time, but fire them to Andre, I'll duck. So Andre, well, okay, in the last 2 minutes, then we might be able to run slightly ahead of time. Let me ask you a question. What do you think are the big unanswered physiological questions with this disease? If I said I can give you the answer to everything you wish to know, I've got the magic recipe book of COVID here, what would you want to know?
Thanks for that, Hugh. I'd want to know why they're so hypoxemic so early, and why our brains don't detect that hypoxemia. Because it's striking that people can have PO2 saturations in the low 80s and yet be comfortably texting on their phones. So that's a truly striking thing. So I wonder about viral neurotropism. And then I'd also like to know exactly how the thrombotic complications occur, because I don't think anyone agrees on that. And I think it's a hallmark of this disease.
Okay, so the gauntlet's down then for our excellent speakers in the coming sessions to answer Andre's questions, and there'll be fines if they don't answer them. Is that right, Andre?
Yes, indeed.
Right. For Susan and others then, do we want to move forward to our next speakers? I'm afraid I'm on the intensive care unit, so I don't have the agenda right in front of me.
That's fine, yes, because we've only got 1 minute left, so that would be great.
Splendid.
Thank you very much.
Well, who's next up then?
We have
Andre, thank you again.
we have the respiratory session, which is chaired by Gareth Ackland, and we're having Luciano and Claire speaking.
Fantastic. And who was on the line? Have we got Gareth and the others with us at the moment? I know we're a little early, but
I'm not sure about that. I think that's over. You have to join the next session. So this session will end. If you can all end this session and you join the next session. So we look forward to seeing you all over at the next session.
and thank you very much again to Andre for leaping in there.